Okay. Bismillahirrahmanirrahim. Let's start today's session. So we will be starting from the major trauma, what we will discuss. So first of all, we need to define what major trauma is. Okay. We have a certain criteria given by RCAM. If patient falls in this criteria, in one of them, then we say it's a major trauma, right? If the patient has fall of more than 2 meters, if the collision is high-speed motor vehicle more than 40 miles per hour, okay, or if in that incident there is death of another individual, or pedestrian is thrown up or run over by the vehicle. So these things come under major trauma. So how do we deal with major trauma? We do primary survey, we manage the patient ABCDE, we do secondary survey and do definitive management. And we will discuss it in primary survey topic. Okay. There comes primary and secondary survey. Whenever there is any incident of the trauma, you get a call from the ambulance crew. So what do? You prepare the team, you announce the trauma code, and you liaison with the laboratory. If in any case there is massive hemorrhage, then you are able to initiate the massive transparent protocol on time. And one more important thing in the trauma, that is lethal triad. Can anyone of you tell me what lethal triad is? Piece of trauma. Basically, in trauma, what happens with the patient? If there is a fracture of long bone, or there are any lacerations or injury to the major vessels or small vessels, there is hemorrhage. If there is massive hemorrhage and that is leading the patient to hypothermia, temperature is decreasing, and when you start massive transfusion protocol, you may incur the acidemia in the patient. Okay, massive hemorrhage, acidosis, and hypothermia. This is the combination of deadly triad. If patient undergoes in this vicious cycle, then the prognosis is very poor. So in case of major trauma, we have to prevent the patient. We have to manage accordingly, right? If we are initiating massive transfusion protocol, we should give the blood components in proper 1:1 ratio method, and we have to manage the temperature of environment as well. Next, we have our question. There is a 26-year-old woman brought to the emergency department by the by the paramedics, following a house fire. She's alert, talking with the horse rise. You note stridor and singeing of the nasal hair. She has full thickness burns to an estimated 30% of total body surface area. What treatment does this patient require as priority? So we have been given a scenario of trauma related to the burn injury, right? And we have been asked the management or treatment on prior basis. So you have to uh, devise this strategy, what you are going to address first, then secondly, then thirdly, then fourthly. Okay. I'm reading your answer from chat box. Any answer input on this? Look, we have option A, refer to the burn center due to facial burn. Start IV fluids, secure airway, start high flow oxygen, treat with IV hydroxycobalamin. If I say all these options are right, so SBA means single best answer. So you have to choose according to the demand of the examiner. What would be priority in all 5 steps? We are going to do all 5 steps with the patient to manage the patient. But what would be our priority? Secure the airway and with the
EPT. Mm.
okay. And could you tell me the rationale for this? Why have you chosen this option?
It was a strider and force voice.
What does it indicate? So there is history of fire in the house. Okay. Patient
Yes,
is alert. GCS is still 15. Patient is talking, oriented and conscious.
with hope
But there is
voice strider.
side and singeing of nasal hair. So what these three things tell us? They tell us about the inhalational injury.
Mm.
In inhalational injury, what is our main concern? Whenever patient of the trauma comes, we address the A, B, C, D, E, right?
Airway breathing
So in
circulation.
inhalation, our main concern. This stridor, singeing of nasal hair, and hoarseness of voice, what is telling us that inhalational injury of the oropharynx and laryngopharynx. So what could it lead to? It can lead to laryngeal edema. So in no time, patient will develop laryngeal edema and we are not able to
Down.
secure the airway. So we have to apprehend in advance and we have to do elective intubation before patient loses airway. One more thing, if the patient comes late, patient has developed laryngeal edema, what will you do? And it is very difficult to pass ETT now.
Fiber optic device. Fiber optic laryngoscopy.
So, okay, you can
Mm.
take the help of fiber optic laryngoscope. But
Mm.
so this is the oral cavity. Okay, what do we have over here? Epiglottis. Behind the epiglottis, we have vocal cords, right?
Mm.
Here is tongue. We are not able to see this palate hard palate. Okay. After the laryngeal edema, these vocal cords are completely closed. Okay. And fiber optic is a fancy thing that is not present in emergency department. Okay.
Mm.
So stick basics. While you are going through the algorithm of airway management, when you are apprehending any difficult airway, what will you do? On the backup, you will plan surgical airway trolley, right? In case of
Tracheostomy.
inhalational
Mm.
injury, yes, our
Mm.
priority is secure the airway. If you are
Mm.
not able to pass the ETT, then at the backup, you must be having surgical airways ready, right? You can do tracheostomy as well. Okay,
Yes.
one thing we have discussed this option. Now, one more thing, IV fluid, Parkinson formula, we will discuss in one topic. Okay, high flow oxygen, we will give it cyanide poisoning. The antidote for cyanide poisoning is
And toxicology.
hydroxycobalamin, and we will discuss in toxicology chapter. So, the main purpose of discussion of this MCQs was how you align your steps in case of trauma patient. So we knew all these options are right, but we have to choose the single best. Secure the airway with ETT. Next question, what do we have over here? A 30-year-old man presents in the ED department with a closed head injury following an RTA. On examination, you note sluggish left pupil, right-sided hemiparesis, and GCS of 7. What should be your next step in this patient management? Carefully read the examiner demand, right? So patient of RTA coming with GCS of 7, okay, having sluggish pupil and right-sided hemiparesis. So what would be your management if I open the chat box? ABCD. if someone has mentioned the LMA and IGEL in previous question, whenever you do not have a pathway to deliver the oxygen, how will LMA or IGEL will work? So we have to bypass the obstruction. That's why we were discussing about surgical airway, BBB, intubate and hyperventilate. It is a rule of thumb whenever GCS of the trauma
Less than
patient is less, so
8
less than 8, you have to intubate the patient because patient GCS may deteriorate further and he may lose his airway. Okay, this is a case of RTA. Patient is coming with head injury. So this option is also right. This is also right. This is also right. Okay, we have to choose the best one. Initially, you have to follow the ABCD, right? In A, you have secured airway, intubate the patient and hyperventilate. Why we are causing hyperventilation of the patient? Any logic or reason why we are doing hyperventilation in this patient? Yes, to get rid of carbon dioxide to
carbon
decrease
dioxide.
CO2. What will it do?
Mm.
It will do veno
It will
constriction
do
of
greater direction. Mm.
vessels. So ultimately, what will it do? It will reduce the ICP. So in case of head injury, the management, while we are doing management of airway, we have to take care of the right. Okay. We will discuss about the primary and secondary brain injury. Just a second. Okay, head injury we have classified into two major themes. One, primary injury, second, secondary injury. Primary injury, direct hit to the brain. There might be contusion, any hematoma, or diffuse axonal injury. They fall under the category of primary injury. Whenever patient of head injury comes to the ED, he has primary injury. What is our target? To prevent the secondary injury, right? So we have to prevent the secondary injury. How can we prevent it? We have to apply oxygen if patient undergoes in hypoxia. We have to maintain the volume. We have to maintain the cerebral perfusion pressure, intracranial hematoma if we are able to evacuate, and we have to manage the raised IC. We have to also manage the normal glycemia as well, right? Okay, cerebral perfusion pressure. Why it is important to maintain to prevent this secondary brain injury? We have formula for cerebral perfusion pressure. Mean arterial pressure
Minus ICP.
minus ICP. So we have this
Mm.
thing. If ICP raised, cerebral perfusion pressure would get compromised, right? So we have to manage ICP to maintain the CPP. And how do we manage the ICP? What is the first step if patient is coming to you? One, if patient needs intubation, you have intubated and you cause hyperventilation to get rid of the carbon dioxide.
Carbon dioxide.
So one thing is that you have done intubation and hyperventilation. Okay. And the most important thing, the most prior step before intubating and doing this hyperventilation, what will you do? According to algorithm, patient coming to you in emergency, you have evaluated the patient, you suspect raised signs of raised ICP. And how do we know patient is having raised ICP? Via Cushing reflex. What is this Cushing sign? Pushing sign tell us about the raised ICP and what are its components. Patient would be in hypertension,
Mm.
bradycardia,
Bradycardia.
yes, and shallow breathing, right? We have appreciated the pushing reflex. We know patient is having raised IC. First and foremost step would be elevate the head end to 30 degree. Okay. Second thing, hyperventilate the patient. Third thing, depending upon the pressures of the patient, depending upon this mean arterial pressure. Okay, what will we do? We have certain drugs. Like in previous MCQ, there were option of 3% hypertonic saline and
Mm.
mannitol, and you will choose one of them according to the pressure. If pressures are low, you will hypertonic saline. If pressures are higher side,
Okay.
then you choose
Narcotic I.
mannitol.
Mm.
Okay. One more thing to be discussed over here is, are you aware of Monroe-Kelly doctrine? Can anyone tell me about Monroe-Kelly doctrine? What it is? You know, our skull is a constant container, rigid box. Okay, it cannot expand it. Whenever there is injury to the brain in a closed cavity, what happens? We have components of the our skull. What do we have? We have brain matter, right? We have different vessels, arteries, and veins, and we have CSF in which brain is floating. We have three component cavity. Whenever there is injury to the brain, there is sharing of these vessels and development of hematoma. So hematoma, it is occupying this space, it is expanding. So if one component is increasing, then second component should have to decrease to maintain the normal physiology. According to hematoma, and it is expanding. Here it is a closed cavity. Cavity is not accommodating this expanding hematoma. It is pushing and causing more pressure in this cavity. So what happens? ICP will further raise. If we do not manage it timely, ICP get on raising, and there would be herniation of the brain, right? Leading to the uh, brain death or brainstem death. So this was Monroe-Kelly doctrine associated with the trauma to the head, right? So these things are clear till now. Cerebral arterioles remain sensitive to partial pressure of carbon dioxide. If there is raised PCO2, there is dilatation and increased ICP. That's why we have to hyperventilate, get rid of this. When there is decreased PCO2, there is vasoconstriction or venoconstriction, and it would lead to decreased ICP. Some important points to be noted: if GCS is 8 or less than 8, then you have to early involve the anesthetist. So this is the thing which I was discussing in the group today, that there are some domains of ED physician, what you have to do, and at which step you have to take the help of other disciplines, right? If you are skilled enough to intubate the patient, but there is a protocol that first you have to call and take help of the anesthetist, right? So while doing MCQs, keep these things in mind, right? So you will call the anesthetist for help and manage the air. Clear so far? Any question from this slide?
That's clear.
Okay. Primary brain injury prevent going into scanty. One more thing, are you aware of penumbra? It is not related to trauma head. It is related to the stroke, but let's discuss it over here. What is penumbra? Actually, whenever there is a stroke, there is blockage of cerebral vessels. Okay. And after the blockage, the distal area gets affected, gets ischemic and necrose. Okay. And it can mimic as, it can manifest as stroke. One thing, the area which is completely affected by low perfusion has got necrose schemed. That is the core point. Surrounding it, we have a larger area where blood supply is compromised, but it is not completely non-functional. Electrical activity might have gone, but metabolic activity remains there. So if you do all these things to maintain normal oxygen, SpO2, normovolemia, normoglycemia, and prevent the patient from secondary brain injury, then you can salvage this outer area. This area is penumbra. This is imminent or susceptible to get damaged, but due to your early involvement and management, you can salvage this area. So this was another term. You might study it in neurology SLO1. Okay. Signs of base of skull fracture. You can see in this picture, there could be hematoma, okay, around the orbital region. That is called panda eye or raccoon eye. One sign. Second sign, you might have subconjunctival hemorrhages in which you cannot appreciate the posterior margin. If the subconjunctival hemorrhage is due to other organic causes or diseases like in croup, you are able to see the posterior margin of subconjunctival hemorrhage. Like hemorrhage is there, and posteriorly you can appreciate the little whitish part of the conjunctiva. Okay. But in traumatic, it is most commonly, you are not able to appreciate the posterior margin. Panda eye subconjunctival hemorrhages, then comes hemotympanum. Hemotympanum means blood coming from the auditory canal. Blood can come from the auditory canal, CSF can come from the auditory canal, and CSF also come from the nose as well, right? So CSF rhinorrhea is another sign, CSF otorrhea is another sign. Then comes a battle sign over the mastoid process. You have bruising and bumps over here. These are signs of base of skull fracture. If you suspect them, you have to advise the CT then and there. Okay. Uh, if whitish secretion are coming from the nose, right, after trauma, how would you appreciate these are not nasolacrimal secretions or secretion from the nose? These are CSF. How will you appreciate that it is CSF coming from the nose, not local secretions? Beta transferrin tau protein. Yes, you do a bedside test. Okay. On bedside test, you have a people and you put the CSF over there. There is bloating and there becomes a circle. From that, you can appreciate it is CSF or not. That are tau protein beta transfer. Okay, have a clear picture of these signs. Raccoon eyes, hemotympanum, battle signs, panda eyes, and you can see you are not able to appreciate the posterior margin of conjunctiva in subconjunctival hemorrhage in case of base of skull fracture. Then we have types of hemorrhages. You can see over here from the shape of hemorrhages, we have given different, we appreciate by the shape, but we have given the name according to their anatomy. Okay, if the hemorrhage is between the skull and dura mater, we call it epidural hematoma, and its shape on CT is biconvex or lemon shape, right? Then we have another type of hemorrhage that is in between the dura mater and arachnoid mater. It is convex shape, concave shape, and are crescent shape on the CT, right? This is subdural hematoma. Then in arachnoid spaces, we have arachnoid hemorrhage and the deform which has no proper shape. There are hemorrhages in the brain that are called ICB, intracranial hemorrhages. Epidural hematoma. So blood collects in the potential space between skull and dura mater. So as we have discussed that skull is a non-expandable rigid cavity. So if the blood is getting accommodated, it is pushing this structure. You can see midline shifting over. Am I audible now? Can you listen? Okay, thank you, Dr. So we were
Yes.
discussing epidural hematoma. So college have asked in previous exam about the pathophysiology or structure involved in epidural hematoma. There is damage to the middle meningeal artery on CT. Okay, then there is one more thing associated with the epidural hematoma that is called lucid interval. And can you tell me what lucid interval is?
A brief period of unconsciousness.
Brief period of consciousness. After
Unconscious.
the incident, patient regains the consciousness, and while hematoma gets on expanding, patient GCS is 15, patient get neglected after that if the investigation has not been done properly or if patient doesn't reach the hospital timely. So hematoma gets on expanding, ICP gets on raising. So what will it do? It will further lead to brain death. So you can, and in scenario, they can mention about it that after the incident, patient was having 15 GCS, talking normally, behaving normally. So that means the examiner is talking about lucid interval. Then we have subdural hematoma. You all are aware of its recent shape on the CT. Uh, if we discuss about the anatomy of it, it is formed between the dura mater and arachnoid mater. And the vessels which get damaged are dural veins. In case of epidural, that was artery, middle meningeal artery. Now it is vein, right? Most commonly, the affectees are elderly and chronic alcoholic.
Alcohol.
Means hyperdense white crescent-shaped lesion that cross the suture line. Okay, this was subdural. Next, we have subarachnoid hemorrhages. Okay. There is disruption of parenchyma or subarachnoid vessels. So you have a pattern of hyperdense area over here, right? One more thing, you have blood in CSF, but that is called in medical jargon what we call
Enthochromia.
xanthochromia, right? And treatment is hemodic. So whenever the patient of head trauma is coming to us, we have discussed briefly, not in detail, that we will do primary survey. We will manage the ABCD. So what will you do in case of subarachnoid hemorrhages? If the patient is losing GCS and it has come to 8 or less than 8, you will intubate the patient, secure the airway and breathing for the circulation. Most of the time, subarachnoid hemorrhage is a result of hypertensive emergency. Okay, we will discuss what hypertensive emergency is and how it is different from hypertensive urgency. So most of the time it is result of hypertensive emergency. Blood pressure raises to that level that if there is AV malformation or there is any aneurysm that gets ruptured, okay, or the vessels are fragile that also get ruptured. So patient is coming to you, and how will you manage it? You manage the ABCD in C. So you will maintain the normovolemia, okay? Get IV access, give fluid if needed or not. So your target to maintain the systolic. In hypertensive emergencies, it is said that you have to decrease the blood pressure 25%, otherwise, what will it do? It will further causes secondary brain injury and can further deteriorate, right? Nimodipine, why it has been mentioned about the nimodipine over here? It delays the blocker. We have to give 60 mg or hourly, okay? Up to 21 days you can give it. Okay, you can also control the BP if it is more than 200. Our target is to decrease a 25% to keep it in range of 150 and 160. You can take the help of labetalol as well. This was the ED management. If they ask about the definitive management of the subarachnoid hemorrhage, what would it be? What is definitive management?
Nimodipine.
It is initial management. You are reducing the morbidity. With the help of nimodipine, you are reducing its expanding. Initially, first tell me about the initial investigation. Initial investigation is CT brain, non-contrast, CT head. And definitive investigation is CT angio of the brain. Why? For this angio, we have to look for aneurysm or AV malformation. Then what will we do? We take the help of other department. What will they do? They will do coiling of the vessels or clipping of the vessels. That is definitive management. So that it may not keep on bleeding and investigation about the subarachnoid hemorrhages. Then comes a diffuse axonal injury. Diffuse axonal injury has very poor prognosis. Okay, CT punctate hemorrhages, most of the time on 90%, you do not have any finding on CT. So investigation of choice. What picture are these? Are these picture of CT or any other modality?
MRI?
Yeah, this is MRI. So in case of diffuse injury, the definitive investigation or gold standard is MRI, where you can find the findings. But in CT, it is mostly more than 90% unremarkable, right? But you have on MRI punctate hemorrhages. Okay, there is injury along the gray and white junction of cerebral cortex, and it has very poor prognosis in case of diffuse axonal injury. And what would be the mechanism of injury in this case? It is mostly due to accelerating, decelerating, shearing forces, like in case of trauma in a motor car or vehicle, where you have poop and counter poop injuries as well. So now you are aware of what are types and how you recognize them, types of brain hemorrhage and how do you recognize them. Now we have a question over here. We have a 30-year-old man has been involved in RTA and has suffered a serious head injury. His CT scan revealed a moderately sized extradural hematoma. His vomiting has reduced GCS, and neurosurgical team is concerned about the possibility of raised ICP. The patient is intubated by anesthetic team and a dose of mannitol is administered. Which further measure could help to reduce his intracranial pressure in emergency department? Select only one answer. You might find more than one answer correct, but you have to choose the single best. B. So we have discussed it in some detail that what will you do in emergency. First step, you have to elevate the head end to 30 degree. Okay. This was a very simple MCQ regarding ICP. Now we have a 23-year-old man brought to the ED. He is unconscious. He was punched outside the pub and fell on the floor, hitting his head. So this is a head injury. Witness describes an immediate loss of consciousness. He has been intubated and ventilated by a pre-hospital critical team. A CT head shows left sideral hematoma. What is the most likely pathophysiology behind this? So we have discussed in epi and in subdural which vessels get damaged. A. Right. So here middle meningeal artery has been damaged, leading to epidural hematoma. Now, indications of the CT head, you have to cramp them. Okay. So we have a certain criteria when we are going to advise the CT within 1 hour and when we are going to advise the CT within 8 hours. In adult patient, if patient coming to initial GCS is less than 30 and after 2 hours it becomes less than 50, then you have to advise CT in 1 hour. Greater than 1 episode of vomiting, you know signs of base of skull fracture, right? Open or depressed skull fracture, post-traumatic seizure, any neurological deficit, like exam, there are some tricks. Am I audible?
Yes.
Is it clear so far? Do I need to revise anything? Any
Uh,
query?
It's clear.
no.
Okay. If you have any query, you can stop me and unmute yourself. Okay. It is mentioned GCS less than 30. So we get confused sometimes. GCS less than 15. So in scenario, they will give you a GCS of 30 and you will sometime in hurry, you pick that you have to advise CT in 1 hour. Will you do it? It is a common human act. Sometimes we don't notice these things. Patient after head injury is coming to you with GCS of 30. Will you go for CT within 1 hour?
No, it says less than 30.
Yeah, exactly. This is the point. Sometimes we get trapped over here. GCS of 12 11,
less
10,
than 14.
and for less than 15, it should be at least 14, 14, 13.
Yes.
I think in adults, number of episodes of vomiting are different as compared to peds population. So you will also have to remember the city criteria in peds population. And how will you keep all these things in your mind? First, what will you do? The common things in peds and adult, you will write in first order. So these are the common, like base of skull fracture or post-traumatic seizure. These are common in peds as well as in adults. You will write it on one page. And the things which are different from adults, you will add extra notes on other column, traditional notes for peds. So it will become easy for you. You don't have to memorize the two tables. You can combine the common factors and additionally you can note down on the sideline, right? So this was the criteria for the city within 1 hour, and was most important thing is when you are advising the city within 1 hour, you should make sure that you get the city report within 1 hour also. Okay. Next criteria within 8 hours. Old age, more than 65 years, patient is on anticoagulant, but our patient is having any bleeding or clotting disorder, retrograde amnesia of 30 minutes, dangerous mechanism of injury, and there are criteria for dangerous mechanism, like pedestrian or cyclist is struck by a motor vehicle, fall from 1 meter, 5 stairs, occupant ejected from the vehicle. Okay, here you can apply a rule of law 135 in case of dangerous mechanism. If they mention about meter, it is 1. They mention about meter, it is 3. If they mention about stairs, it is 5. Right? Meter, stairs. You have to look at this. Now we have indication in children. So first we will find the common thing, city within 1 hour, right? Focal neurology, uh, focal neurologic deficit, common. Post-traumatic seizure, common. Base of skull fracture, open skull fracture, common. The additional point you will mention along with that table is suspicion of NAI. Okay. In less than 1 year age, those swelling or laceration, any type of wound more than 5 centimeters on the head, you will advise it within 1. Uh, what about the first two parts? In peds population, we have lower threshold in case of head injury. In adult, it was less than 13. In peds, it is less than 14. Like on 13, if the patient is adult, you will not advise the CT within 1 hour. But in case of peds, the GCS 13, you will advise CT within 1, right? And less than 15 is common in 2 hours. Okay, this was the criteria for 1 hour sitting. Then there is criteria one more. If we have advised the city within 1 hour, if we have any one of the following, we will wait for an other indicator. Okay. In this table tells us here you will straight away go for city within 1 hour if one indicator is present. If in this case, if one indicator is present, you will look for another indicator. You have more than one indicator like 2, 3, 4, then you will advise city within 1 hour. If not, one indicator is present, then you will wait for 4 hours. And in these 4 hours, you will look for these three indicators. If you found them, then you will advise the city. Okay. Loss of consciousness of more than 5 minutes. Normal drowsiness, 3 episodes. Okay. In adult indicator. here more than 3 episodes, and this is just a 50% indicate. Like you have to get 100% evidence, two indicators for this. Dangerous mechanism of injury. Okay. The above risk factor is present, then observe for 4 hours. Then you will see if GCS further drops, and other episode of drowsiness, same thing. Drowsiness or GCS dropping, same thing. Or further episode of vomiting. Okay. There is no concept behind them, but you just have to memorize them like this and make your own notes to make it easy for you to revise. Next. Okay, indication of cervical spine. These indications, mostly in case of trauma, cervical spine, we follow Canadian spine. And what is Canadian spine? In this slide. Okay. If you have high risk factor, if you have low risk factor or no low risk factor, then what will you do? There are three high risk factors. What are they? 65, fast drive, sensory deprived. If age is more than 65, then this is a high risk factor. You will go for radiograph of the cervical spine. Fast drive means dangerous mechanism of injury. And what are those dangerous mechanism of injury? Fall from 3 feet, 5 stairs, 1 meter. Axial load to the head of diving. Motor vehicle collision of high speed, more than 100 kilometers per hour, right? Okay. In slide 1, we had discussed the criteria for major trauma. That was 40 miles per hour. That was definition of major trauma. So here we have approximately 6 kilometers are in 1 mile. This becomes 65. But here we are discussing about the indication for radiograph or CT scan of the cervical spine, right? A dangerous mechanism, motorized recreational vehicles like Formula One racing cars, bicycle stuck by the collision. Okay, these are dangerous mechanism of injury. One age, second fast drive, dangerous mechanism of injury, then sensory deprived, that means paresthesia of upper or lower limbs, paresthesias of the extremity. These are three major risk categories. If you have any one of them, then you will go for CT cervical spine. If you do not find any of these high risk factor, what will you do? Then you will look for the low risk factor. If low risk factor are not present among any of them after major trauma or injury to the cervical spine, if you are suspecting, then you will definitely go for CT cervical spine if you do not have low risk factor. Okay. If you have any of these low risk factor, what will you do? What are these low risk factor? Motor vehicle collision from the rear end. Patient is ambulatory at any time. There is delayed onset of neck pain or absence of midline cervical spine tenderness. If any of these low risk factor is present, then what will you do? You will ask the patient to rotate the neck and comfortably rotate his neck. Then you rule out cervical spine injury. If patient is not able to move his neck, then what will you do? Then you will advise CT scan of cervical spine. Okay. Is this mnemonic helpful? 65 fast drive and sensory power. One more thing. Slow neck, slow rack, don't do X-ray check. What does it mean? Slow neck means patient is able to move neck slowly, but he's able to move and no pain. Like in this case, he is able to rotate at the 45-degree right to left. Slow neck means not dangerous mechanism of injury. The mechanism of injury was low energy force. Then you do not have to go for X-ray check. Okay. Then if you have fast track and old or numb neck, do X-ray check. What does it mean? Fast track mean dangerous mechanism of injury. Old mean more than 65-year-old. Old neck or numb neck, like there are paresthesias. Then you will go for radiology of this spine. I hope I try to make Canadian spine rule easier for you. You just have to revise these things and apply while attempting the MCQs. Okay, any query? Any questions so far? So I have okay. Any questions so far? Am I audible?
Yes, you are audible.
Okay. So we are almost near to complete the head injuries. So risk factor for the thoracic or thoracolumbar spine injury if age is more than similarly 65, pain in thoracic lumbar spine, dangerous mechanism of injury, pre-existing spinal pathology, like in case of osteoporosis or any previous spinal fracture in another region, patient is manifesting paresthesia or weakness or numbness of the limbs. So this is MRI of the spine. You can see normal anatomy. These are vertebral bodies, intervertebral disc. Here we have spinal cord. Over here, you can see after the fracture of this vertebra, you can see there is compression. The bony part is compressing over here, and you will find the findings below this area of finding in the body below this area. Okay, this is how compression of spinal cord looks like on MRI. Spinal immobilization, maintain full inline immobilization. If a high risk factor, like you have to apply Canadian spine rule, if that is present, you have to do inline mobilization of cervical spine to prevent the further uh, damage or injury to the spinal cord. And if a low risk factor Canadian spine rule is present and patient is not able to rotate his neck, then definitely we have to immobilize the neck and then send the patient for the investigation. Okay, do not maintain full inline spinal immobilization if low risk factor for the cervical spine, patient is pain free, able to rotate the 45 right and left. Cervical spine C1 to 7 is very vulnerable to the injury as it is the most exposed area of the spine. Okay. Then AD management of raised ICP, I guess we have discussed this a bit by bit in previous slides. First of all, you have to raise the head position to 30°. Then you can cause hyperventilation, keep the PCO to 4.5 kPa. In Pakistan, we study about millimeter of mercury, right? And range is normal range of PCO2 on ABG is what it is 35 to 45. And if you convert this 4.5 to 5 kPa, then the range becomes 34 to 38 almost. What does it mean? That you have to keep the PCO2 at lower normal limit, right? Do not deteriorate the physiology of the body by uh, doing hyperventilation aggressively. Just you have to keep PCO2 at the lower normal limit. You can give mannitol and hypertonic saline depending upon the blood pressure of the patient, right? Okay, observe for the admitted patient with the head injury. You have to do neuro observation. What comes under the neuro observation? You have to frequently assess the GCS of the patient, check the pupil reflexes, pupil size, reactivity to the light, limb movements, respiratory rate, heart rate, blood pressure, other vitals, and oxygen saturation, and prevent the patient from secondary brain injury. Timing of observation: if the GCS is less than 15, you will do half hourly monitoring until the GCS is regained to 15 again. Then half hourly for 2 hours, then 1 hourly for 4 hours, then 2 hourly thereafter. This is monitoring of the patient with the head injury who has raised IC. Devastating brain injury, a condition which is deemed to be non-survivable with no benefit from the neurosurgical intervention. Okay, what will you have to do? You do not withdraw the life support immediately. You have to give proper treatment protocol in ICU care for 48 to 72 hours, admit the patient in ICU and reassess the patient every 24 hours. Okay, if there is improvement, then you will review the management plan and do accordingly. If no improvement, then you have to withdraw the life support. And if the devastating brain injury isn't improved after 72 hours of life support, then consider organ donation after cardiac death. Okay. Third pathway of the algorithm is if the patient is having devastating brain injury and it progresses to brain death, then you will test and confirm the brain death and offer organ donation after the brain death. Now, let me know, how do you confirm the brain death of the patient? What maneuvers we can do to confirm the brain death of the patient?
Checking pupils.
Yes, very good. You check the pupil. If pupils are what?
Fixed dilated.
Yes, fixed non-reactive to light. Second thing, what can you do?
We can check for eye reflexes.
Okay, you can check corneal reflexes. Okay, no eye movement. So pupil reflex and corneal reflex can be applied to know about the brain, but they are not more reliable and more specific. They are additional supportive evidences. Okay, what else we can do? We can do apnea test, we can do test, we can do oculocephalic reflex. What is oculocephalic reflex? We move the patient head and we see eyes are not moving with the direction of moving head. So they are fixed. We call them doll's eye. One thing is second caloric test. How we perform? We put cold water in the ear of the patient and we do not appreciate any eye movements. That is caloric test that also tells us about the brain death. And there is apnea test if patient is on ventilator. So you pre-oxygenate the patient to 100% saturation. Then you disconnect the circuit and check the spontaneous breathing. Putting cold water in, yes, that is caloric test. Okay. In this way, you are able to appreciate the brain death and you can offer the organ donation. You will know about the organ donation criteria in SLO 7. Okay, we will discuss that. and who is not able to donate the organ, there are some criteria as well. So they are also very high yield for the exam. So here we have another question. "25-year-old man is brought in by ambulance following a fall down a flight of stairs. He lost consciousness in a few minutes. He opened eyes spontaneously, withdraw his arms from painful stimulus, and is slightly confused, disoriented. What is GCS?" Okay, we have been discussing about the brain injury and how we monitor the patient by assessing the GCS, and you should be aware of how to calculate the GCS. They also ask in the exam as well. Is my net stable? Are you able to hear me and see my screen as well?
Yes, but we cannot see the question on the screen.
Uh, just give me a second. Now we have this question. 25-year-old fall from stairs, unconscious for a few minutes. He opens his eyes spontaneously. Okay. Opening eyes spontaneously. Withdraws his arms from the painful stimuli and is slightly confused and disoriented. If we break down EVM, what is the of this patient? Patient is opening his eyes spontaneously. That is 4.
Or
4 for eye, E4. If patient opens eyes on command, then 3. If on stimuli, then 2. If patient doesn't open command, then we also give a number, right? Then V5, right? Verbal. If patient is oriented, right, and able to converse normally, then we give it 5 number. Patient is confused, like in our scenario,
oh,
it's confused, we give 4 number. So E was 4, V is also 4. Okay. If patient is confused, disoriented, we give 4 marks. If patient utters just words,
Inappropriate.
inappropriate words, then we give 3. If incomprehensible sounds, 1.
Sounds two.
Voice, sorry, incomprehensible sound, 2. If no voice, 1. Right? Then motor has 6 components. Patient follows the command. Okay. Then you give 6. Like you say, raise your hand, patient is able to follow your command, and you will give show your tongue, patient is able to do that. Number 5, patient is not following your command, like he is not oriented well. Then what does he do? You give a pain. Patient is able to localize the pain, right? Painful stimuli, he localizes it, you give 5. Then another thing, patient causes flexion, withdrawal, right? Here in our case, withdraws the arms. So in this scenario, M is also 4. Patient follows command, right? Patient localizes pain. Patient withdraws from the painful stimuli. Number 3, abnormal function. That is called decorticate movements like this. Then comes number 2, decerebrate movement. Decorticate and decerebrate. Abnormal flexion and abnormal extension of the limbs. If no movement on painful stimuli, then 1. So GCS is never 0. You have to assign 1 number on each component. So minimum GCS is 13, maximum 15. But in this scenario, open eyes spontaneously, withdraws arms, and confused. So confused and withdraws arms. So our answer would be 12, right? I hope it is clear now. So this is the table for the GCS. I don't think we have to go through this again. It's very easy. Like you have to read it from 4 to 1, not 1 to 4. That would be very easy. Spontaneously on pain, on command, on pain, no opening. Oriented, confused, inappropriate, incomprehensible words, no sounds. Obeys command, localizes pain, flex, withdrawal of the painful stimuli from abnormal flexion. Okay. That is called decorticate. And abnormal extension, decerebrate, no movement, none. So this was all about first topic of the major trauma, that is head injury. Okay. Next, we have cervical injuries. We will discuss in next session. Okay. If you have any query, if you want to ask anything or want me to revise anything, you are more than welcome. I hope you enjoyed the session. It was fruitful for you. Any input from any candidate, more than welcome. Okay, thank you everyone for joining this session.